You're listening to Clinical Conversations, a Journal Watch podcast for the week of May 29th. I'm Jelia. Call us at 1-617-440-4374 with your suggestions. Or write to jelia, that's Jelia, at NEJM.org. This week we've got an interview with Professor Martin Dennis. His paper in Lancet will have people thinking about the use of compression stockings after stroke. I'll look at the other clinical news first. A Lancet meta-analysis on trials of primary prevention of vascular disease with aspirin finds that it is of uncertain value there. Looking at the results of 6 trials comprising almost 100,000 patients, the authors find a reduction in serious vascular events, but an increased risk for major bleeding. Barrett's esophagus seems susceptible to radiofrequency ablation, according to a New England Journal of Medicine study. Patients were either randomized to endoscopic ablation or to a sham procedure. At the 1-year mark, patients with high-grade dysplasia, as well as those with low-grade dysplasia, showed significantly greater rates of complete eradication than the controls. The FDA has approved tolvaptan for use in hyponatremia. Tolvaptan is a vasopressin receptor antagonist and can only be given in the hospital so that careful monitoring of sodium levels can be assured. Now, on to the interview. The Lancet published online this week a study looking at whether thigh-length graduated compression stockings prevent deep vein thrombosis, or DVT, after stroke. The answer, they don't. And that means that guidelines recommending their use will have to change, and rather quickly. Why? Because not only do the stockings not prevent DVT to a clinically meaningful degree, they're also associated with a 4-fold higher risk for skin complications like ulcers and necrosis. The study's chief investigator, Professor Martin Dennis of the University of Edinburgh, has kindly agreed to talk with us. We caught up with him in Stockholm. Welcome, Professor Dennis.
Good afternoon.
So, compression stockings are widely used to prevent DVT after surgery. Why aren't they working after stroke, do you think?
We're not sure. The reason why we did this trial was that we thought stroke patients were rather different from surgical patients. Our patients, I think, tend to be older. We cannot put the stockings on before the patient is immobilized or paralyzed, and it's often a day or two before the stockings are actually applied. Mm-hmm. And of course, deep vein thrombosis may have occurred in the interim.
I see.
Also, our patients have comorbidities. They've got problems like diabetes and peripheral vascular disease, perhaps in 10-20% of people. And that increases the risk of complications from stockings. So we thought it was worthwhile seeing whether the stockings work in stroke patients as well as surgical patients.
Were you surprised at the findings? This is a large study. It's about 2,500 people in the UK, Italy, and Australia, right?
Yes, it's by far the largest trial up to now. The guidelines guiding the use of stockings in surgical patients are based on 17 randomized controlled trials, but mostly with 100 or 200 patients at most. So this is larger than all of those trials put together. So it's a very substantial addition to the available evidence. And in stroke patients has given us a very precise estimate of the effectiveness or lack of effectiveness of stockings.
And were you surprised to find what you did?
Yes, I think most of us thought that they would work in stroke, perhaps less well than in surgery, but we thought there would still be a useful benefit which would make the continued use worthwhile. But as it is, it looks as if the benefit has been attenuated by maybe the factors we've already mentioned, and that we'll be having to look at alternative methods of reducing the risk of DVT after stroke. In the trial, 10% of patients had a DVT in the popliteal or femoral vein, and this is a substantial risk to patients.
How long have those guidelines been in effect?
We looked at most of the national guidelines available, and certainly the guidelines written since about 2000 in different countries have generally recommended stockings. In some, like the US, the recommendation is that stockings should be used in people who can't take heparin or anticoagulants, whereas in other countries where heparin is less often used because of the risks of hemorrhage, the recommendation is that stockings should be used in all immobile stroke patients.
Uh-huh.
And looking at the data available from other sources, about 2/3 of patients admitted to a hospital with stroke will be immobile, therefore at risk of DVT and PE, and therefore in need of some form of prophylaxis.
This is part of a larger three-part effort called the CLOTS trials, and that stands for clots in legs or stockings after stroke. And the other two parts are comparing, the second part is comparing thigh length with knee length stockings. And the third part is comparing intermittent pneumatic compression with no compression. Now, according to the paper, I think you have stopped the second part, which is the comparison of knee length with thigh length stockings. Is that right?
Yes, we've stopped that trial just this week. We felt that given that the thigh length stockings don't have any clinically useful effect and also have some risks, it would be inappropriate to continue to randomize patients between thigh length stockings and below knee stockings. Also, when we started trial 2, at the same time as trial 1, we believed that our hypothesis was that thigh length stockings would be better than below knee stockings, since almost all of the evidence for the use of stockings in surgical patients comes from the use of thigh length stockings. Interestingly, I'm sure practice around the world varies, but very many millions of patients are fitted with short stockings each year just because they're easier to fit and maybe more comfortable. But there's very little evidence to suggest they work in any group of patients.
And it was interesting that one of the stocking manufacturers donated the stockings for the trial. They must have been disappointed in the results.
Yes, I'm sure they were disappointed, but I think they have to be commended for their continued support of decent clinical research. That particular manufacturer is the only one that has carried out more than one randomized trial of their products in any group of patients. In surgical patients, those have shown that they are effective. In this group, they're ineffective. Yeah. And they're also supporting evaluation of intermittent pneumatic compression.
So the problem is, as you alluded to earlier, is that you have stockings, you have intermittent compression, and you have anticoagulants. But the anticoagulants, you can't just pour those on because they have their own problems.
They certainly do. I think, in addition, it's important to point out to professionals, but also patients, that simple things like ensuring that patients are adequately hydrated, mobilized as early as possible, receive aspirin if they've had an ischemic stroke, all of these things will reduce the risk of deep vein thrombosis to some extent. Not to a known extent, but probably to some extent. But yes, the big issue is the extent to which we should be using standard heparin or low molecular weight heparin in patients with particularly ischemic stroke, which makes up 80% of strokes. Previous trials in 20,000 patients have demonstrated that routine use of standard heparin is associated with, yes, a reduced risk of venous thromboembolism, but also an increased risk of both intracranial and extracranial bleeds, so that the net benefit is cancelled out. There's no reduction in mortality associated with use of heparin, and there's no reduction in morbidity. So this has led to variation in practice and in guidelines around the world, with some countries recommending heparin for most ischemic strokes, and others suggesting that it should be very restricted use to those who the clinician judges to be at particularly high risk of DVT and very low risk of hemorrhage. And of course, we don't have very good tools at the moment to sort those out.
And those patients should be getting low molecular weight heparin?
Well, again, it's difficult to know. There have been one or two trials comparing low molecular weight heparin with standard heparin, such as the Prevail trial published in the New England Journal, I think it was actually the Lancet, a year or so ago. But unfortunately, these trials have been relatively small and haven't been adequately powered to ensure that there isn't a difference in the bleeding rate. So low molecular weight heparin may be more effective at preventing DVT, but we can't exclude a possibility that it could cause more bleeds.
So it looks
in general, though, I think... Sorry.
No, go ahead. You were saying in general.
I think in general, low molecular weight heparin is seen as more convenient, and when we do heparinize our patients, in general, we use this, yeah.
So it sounds like there's a lot more research to be done.
Yes, both new research, but also I think we can make better use of the data we've collected in trials such as the CLOTS trial. We will have, when we've completed CLOTS trial 1 and 2, over 5,000 patients with stroke, and over 500 of those will have had a proximal DVT. We'll be in a very powerful position to identify those factors which are associated with a higher risk of DVT, such as weakness in the leg at onset. Now, if we can use those data to model who's at highest risk, we should be able to also look at data from previous heparin trials to see whether there are factors at baseline which predict who is likely to get hemorrhagic complications of heparin. With luck, we might find that some factors predict high rates of DVT, but are not associated with high rates of bleeding. And that may allow us to model who should be treated with heparin after ischemic stroke.
Well, we'll certainly look forward to those results when they come out, Professor Dennis. And I want to thank you so much for taking the time to talk with us today.
You're welcome. Thanks so much.
We'd like your reactions at 1-617-440-4374. Give us a ring, please, or drop me a note at jelia@nejm.org. Clinical Conversations executive producer is Adore Yano. I'm Joe Elia. Join us next week. Enough said.